Actually, telecardiology started in 1906. The inventor of EKG, he sent the first EKG over the telephone line. That marked of initiation of telecardiology as well as telemedicine. Most people believe he was the father of telemedicine. So technology advanced from telecardiology or telemedicine perspective from two aspects. One is from the technology aspect, another is technology utilization or clinical service aspect. From technology aspect, because of the information technology, because of the device improvement, because the wireless technology development and communications. So that really advanced the technology from the EKG perspective. So right now, in the past, I'll show you the picture, and actually, literally, the person has to sit in front of a big machine. He's put in the hand in a big water tank for conduction of EKGs, and that's how the first EKG was performed. Right now, the EKG device actually is a pocket size of a cell phone, and they can use this wirelessly to connect patients and acquiring the EKG graph and send the EKG to cardiology remotely to perform interpretations and the care. So the second part of it is the utilization of technology. So right now, because of the nature of cardiology, coronary disease number one killer over 100 years, and people has to respond within certain period of time. After diagnosing heart attack of EKG, and they have to be treated within 90 minutes. And within 90 minutes, the reduction of mortality can drop up to 80%. After that, 46 hours after initiation of heart attack, actually become pretty much flatline, meaning even you provide the treatment using thrombolytics or clot buster or angioplasty stent, and you still patient don't get the benefit. So really, the timing is muscle, timing is life. We have to do it really at the early stage. That depending upon of how you make a diagnosis to lead for the treatment. So for my practice, and what we do is we provide all these telemedical as well as conventional care outside of hospital setting. And what we do is we provide the technology. We give the people devices, EKGs, vital signs, and then we connect of these devices, of their readings, measurements with their primary care physicians as well as our monitoring centers. So this way we can monitor patient 24/7 to control of unnecessary admissions, readmissions, which is very hard to do because inside the hospital everything is well controlled. Outside the hospital, because the patient is not connected and it's very difficult to control. That's why the readmission back to hospital is very high. So we started this service about half year ago, and we set it up of these telemedicine settings with individual patient as well as facilities. For example, rehab hospitals, skilled nursing facilities, adult living facilities, or the patient at home. So what we do is we provide the devices, connect the patient, then we have monitoring center. We monitor the patient on 24/7 basis, then provide chronic disease management on daily basis, as well as acute, if a patient have acute presentation, for example, chest pain. One of the typical examples is a patient with a history of coronary disease and atrial fibrillations. Actually, he had ablations twice for the last several years. So this is actually 3 weeks ago, and he had an episode of chest pains and palpitations. Then he performed EKG on himself and sent the EKGs to my phone. When I looked it over, he said he get back to the atrial fib. So usually atrial fibrillation, those patients need to be admitted to hospital. They need to give blood thinners, and they need to stay at hospital a couple of days and convert back to normal sinus rhythm. So in his case, 3 weeks ago, I started medication right away. So within the 48 hours of safety window, we successfully converted him back to normal sinus rhythm based on the EKG readings and also blood pressure readings, as well as a face-to-face virtual assessment. And he's back, convert back to normal sinus rhythm. So we saved a hospital admission, we saved him on blood thinners. So usually when you start blood thinners, people need to be on the blood thinner for 3 months. So it's not very convenient and costly. The second example, actually I got a patient consent, I can tell you more details. He's an 89 years old gentleman, World War II, a retired veteran. Actually he was in a Manhattan project, very smart. But over years he developed heart problems as well as Parkinson's problem. And late in November, he had an episode of chest pain. Called 911, ambulance went to his house, checked him out, but they told him, "Sir, you're fine, you don't need to go to hospital." 1 month later, 1 day before Christmas Eve, he had a similar episode of chest pain. And then by then we have to provide a device, and family said probably didn't have anything because he already had, ambulance already came over, he didn't do anything, but we have a device, we're going to use this, and we try to figure out what's happening this time. They put the device on, the EKG come to my phone, and I look over this, I said, damn, he had ST elevation MI, STEMI. And so I give him medications prepared, and I call the hospital cardiologist on call directly, and then ask him to come to the emergency room to wait for him, because sometimes you have to take a long time to go through the emergency room. Actually, the cardiologist arrived before the patient arrived at the ER. They quickly get him through the ER and send him the cath lab for intervention. While they preparing him, actually he had a cardiac arrest. But the right place, right time, they successfully resuscitated him and put a couple of stents. 4 days later, he walked out from hospital. This is the story really manifested of what the impact of telemedicine and telecardiology can do to diagnose the acute heart attack remotely in his bedroom before his cardiac arrest. Otherwise, the patient will not survive. I really believe this is the future of telemedicine and telecardiology. We need to provide the devices, the connections, the services, and through cardiologists and primary care and hospital services, we can successfully and effectively control of acute heart attacks. So over the last several months, and we have implemented our telecardiology, telemedicine program in the facilities of skilled nursing homes, rehab hospitals, and we provide the devices, connections, and 24/7 services to those people. Over these 3 months of initial phase of pilot, and actually we demonstrated significant cost savings over $100,000. And many patients, and actually over the last several months, there were over 80 calls, only 2 admitted to hospital. One is the patient with acute heart attack, another one is the patient actually demand go to the hospital by the patient itself. And otherwise, we achieved 98% of success rate in this initial pilot study to control unnecessary admission or readmissions. So usually this type of technology is provided by a larger group or hospital settings, because they can, and set up the platform for bigger patient populations and also cover the cost. For individual small groups, it might join the other practices or the network. So in our case, actually we set up a platform of technology in information technology, device technology, and clinical services. So this way other physicians can participate of this platform to provide this telemedicine, telecardiology services to their patient with a lower cost. There are a lot of challenges in terms of utilizing of telecardiology and telemedicine devices and providing services. A few are very important. Number one, this technology is still in the infancy. We have a lot to learn to make it mature, make it more reliable, make it more portable, make it more cost effective, and make it more user-friendly. And also more important, I really believe the most important thing is if we can provide on individual patient, high-risk patient, every one of them, they have a device for a period of time. And I think that will significant impact on the services of the detect of the patient with chest pains. And for example, patient after bypass surgery or stent for a period of time, 3 months or 1 month, to prevent unnecessary readmissions. So that's number one. Number two is the technology platform in terms of exchange data. Because right now, how we integrate the patient care from the devices, the data, with the patient electronic medical records, and across the platform to share the information among the physicians, hospitals, which may not utilize the same exactly of record systems to capture data. So the case what we do is we develop a platform, and we gather information from the patient, from the hospitals, from the physician groups, and we put all things together for the patient. Then we provide access for all these related providers, hospitals, different specialty physicians, including cardiologists, as well as primary care. So this way we can all share the patient information to make a quick decision for acute care as well as chronic care over time on daily basis. So that's number two. Number three is reimbursement. So right now Medicare started reimbursement for telemedicine services, which is quite good. And however, there are insurance companies not provide of the coverage, and they might limit of the expansion of the telemedicine. However, having said that, now the insurance, the laws of different states are moving very quickly, as well as from Medicare of policies. And so I really believe because of this technology and provide better care, faster access, and low cost, better, faster, and cheaper. So the telecardiology is in the infancy, and from the cardiologist perspective as well. One of the challenges is reimbursement and the intensity of the services, because these really require 24/7 services and require the patient utilize the devices, require our physicians to read the measurement from devices, as well as a face-to-face assessment on 24/7 basis. So that's the challenge. However, the technology evolving and the service network forming, I think over time of all the hurdles, the reimbursement, because of cost savings, the technology development, and the social and the service network development, and most of the hurdles will be overcome over time, and by then this technology should be scaled up very significantly. However, this is at the very beginning of the technology, and it will be very good for cardiologists to be early adopters, to be the early users, so they can engage of technology as a leaders rather than the followers for the technology.